Okay, everyone, well, welcome to this VR presentation on knee sonography. As in the others that we've done, I'm just going to run through a basic knee ultrasound that a lot of radiology departments would perform and how they perform it and the images that they would routinely take. So, anatomy revision time. We're going to break the knee up into the anterior, medial, lateral, and posterior aspects of the knee. In the anterior aspect of the knee, we're going to have a look at the quadriceps tendon as it comes down and attaches to the patella. We're going to look at the patellar tendon as it comes down and attaches to the tibial tuberosity. We're going to look at Hoffer's fat pad here between the patella and the patellar tendon. We're going to have a look at the suprapatellar bursa or recess to look for increased fluid. We're going to look on the medial aspect of the knee. We're going to look at this medial meniscus. We're going to look at the medial collateral ligament and this long ligament as it inserts onto that proximal medial tibia. Then we're going to look at the lateral aspect of the knee. We're going to look at this lateral meniscus, lateral collateral ligament. You can already see how the lateral collateral ligament sits separate from the lateral meniscus, different to the medial meniscus when that close or intimate association with the medial collateral ligament. So that's important to be aware of. We're also going to look at the iliotibial band as it comes down the leg and attaches to Gertie's tubercle here in this anterior proximal aspect of the tibia. Then we're going to have a look at the posterior aspect of the knee. We'll have a look at the popliteal artery. We'll have a look at the popliteal vein. We'll have a look at that posterior tibial nerve as well back there. And we'll have a look at the posterior knee joint to look for a Baker's cyst. So let's get started, shall we? So when I examine the knee, I have the patient supine. It's a nice comfortable exam for the patient typically. A lot of ultrasound tables will have a little ridge in the table and they can just rest their heel in that because you want the knee flexed at about 30 degrees. Right? Reason being is if there's excessive fluid in the knee joint, flexing the knee like that will displace the fluid up into that suprapatellar bursa / recess so that you can see it. If the knee's out straight, you may not see if there's a little bit of excessive fluid. If they can't flex their knee, you can ask the patients to tense their quadriceps muscles. That will do the same thing. But having somebody tense their quadriceps for 5 or 7 minutes when you're examining the anterior aspect gets tiring. So it's much easier if they can bend their knee up. Plus, it can help to take pressure off their lower back so they're a lot more comfortable. So for the knee, because it's a bit larger organ, I tend to default to the linear 12-5 probe. I just find that works well. But as always, whenever you get into your department where you're working, experiment with different ultrasound probes. I'm on a musculoskeletal knee preset, so we'll start with the anterior knee, looking at that quadriceps tendon. So the quadriceps tendon, remember, is made up of your rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. So you've got those 4 muscles together coming down, forming the fibres of the quadriceps. So we're just going to adjust our imaging parameters a bit here, bring our focus up. So if we look at our quadriceps tendon, we can see this nice fine fimbrial pattern. I'll just zoom that up a little. Now you can also see these a little bit coarser white lines. They're the different muscle slips. So like your vastus lateralis coming in, forming part of the quadriceps tendon. Perfectly normal. Look as the quadriceps tendon comes down and attaches to the patella. So this is your patella base up here. The patella's a bit weird because the apex is at the bottom and the base is up the top. So this is your patella base down here. We're looking to see for cortical irregularity. We're looking for echogenic spurring coming off the patella there. In the case of fractures, we'd be looking for a step deformity. In this case, this is a lovely normal quadriceps tendon. So this is where I'd take my first image. And then deep to the quadriceps tendon, we have the knee joint itself. So up in here, we've got our suprapatellar bursa / recess. It's normal to see a little bit of fluid in that. So this is a normal amount of fluid. This here, this echogenic white line, is actually the interface between the fluid in the suprapatellar bursa and the articular cartilage covering the distal aspect of the femur. So this is normal as well. This is what we would expect to see. nice hypoechoic smooth cartilage. And that's a normal suprapatellar bursa. That's where I would take my next image. Now, you do have lots of different bursa around the knee. One of the bursa that we examine is called the pre-patellar bursa. So if somebody falls over and lands on the point of their knee, say on a rock or something, the pre-patellar bursa is what can become irritated and swell up. It's also called carpet layers' knees, housemaids' knees, clergyman's knees, lots of different names for it you might see on the referral. But basically you need a little mound of gel. Rest your fingers between the probe face and on the patient, so you can just hover your probe over the skin, and what we're looking for is to see if this is hypoechoic or anechoic area sitting adjacent to the patella. So this is just ultrasound gel. These little white dots are the air in the ultrasound gel, and there's no pre-patellar bursa. We're starting to come into the fibres here of the patella tendon. So we'll examine that now. So here's our patella tendon, which is really a continuation of the quadriceps tendon. Some people call it the patella ligament. It doesn't really matter so long as you know what you're looking for or looking at, and that your terminology is accurate. So here's our patella tendon, nice black, white fimbrial pattern, coming down, attaching to the tibial tuberosity of our anterior proximal tibia. So this is all very normal. Now there's a condition called Osgood-Schlatter's disease, whereby it's like a fusion abnormality in adolescent children, typically adolescent males that play a lot of sport. It's like the muscles are too strong for the ligamentous attachments. And what can happen is you can get a disassociation of the cortical surface here, and it looks like there'll be two white lines. That's Osgood-Schlatter's disease, so this is where you're looking. Now, as we go up, or more proximally I should say, to the apex of the patella, through here is Hoffer's fat pad. Now, just like Kager's fat pad in the ankle, that sits deep to the Achilles tendon, Hoffer's fat pad sits deep to the patella tendon. Now, you can't put a caliper on and go, Hoffer's fat pad goes from here to, say, here. No, it's an area, right? So this is what a normal fat pad should look like. Right? You can see areas like little fine white lines. It's a bit hypoechoic through here. This is normal fatty tissue. When people have a condition called jumper's knee, right, it's an irritation of the patella tendon onto the patella and the associated fat deep to the patella tendon. That Hoffer's fat pad swells up, becomes hypoechoic, and when you put your colour on, as you should always do, it's often extremely vascular. It's a very painful condition, and it's a debilitating condition. So look for that. Now, when we move down the knee back into the patella as it inserts onto the tibia, we have our superficial infrapatellar bursa and our deep infrapatellar bursa. Here's our deep infrapatellar bursa, just sitting through here. And that's normal to have a little bit of fluid. 2 millimetres is perfectly normal. The superficial infrapatellar bursa, you don't typically see fluid in that. That would be abnormal if you saw fluid there. So look at your patella tendon and long, go from survey through it, right, or medial to lateral, and in transverse from origin down to this patella tendon down to the insertion. Look for any hypoechoic clefts, look for any increased vascularity, look at the underlying fat to see if that looks normal. And that's the anterior knee. Now, if we move over to the medial knee, lovely, thank you. So the medial knee is where you often see a lot of pathology in knee ultrasound. So this is distal femur, this is proximal tibia. Between our femur and our tibia, we have the medial meniscus. So this structure here, here's our medial meniscus. This is where we are in the coronal plane. So there's our medial meniscus. So it just looks like any other sort of hyaline cartilage. So it's echogenic. Just adjust this a little. I might just drop my depth down. and increase my zoom a little and drop the focus down. There we go. So it's echogenic and it's an inverted triangle. So your meniscus are the shock absorbers of the knee. So when we walk, run, jump, whatever, they're the things that take that compressive force, they bow out, and then they come back in. So in a normal knee, this edge of the meniscus, when it's loaded, would bow out and then come back in. It's like a shock absorber, it's doing its job. When the meniscus becomes degenerate or torn, instead of, see here, it's sitting about level with the cortical margins of the femur and the tibia, this meniscus will bulge out. That's abnormal. So that's like a shock absorber in a car that's just leaking, right? It's not doing its job anymore. It can't absorb that shock normally. So that's an abnormal meniscus. So we would look for that. Remember, over the top of our meniscus, or our medial meniscus, we have our medial collateral ligament. The proximal insertion onto the femur is a broad fat insertion. Here it is through here. We come down, you see its intimate relationship with that medial meniscus. Continue going down into the proximal tibia. And this is where the medial collateral ligament attaches to the proximal tibia. Now, this is normal medial collateral, nice hypoechoic areas, and then an echogenic or hyperechoic area. So we've got our hypoechoic fascicle surrounded by the hyperechoic endotenon. And then as we come down, see how it swells up and becomes a bit more hypoechoic through here? Reason being is that's where our pes anserine attaches. So your pes anserine is your sartorius, gracilis, and semitendinosus in that order. And a little mnemonic to remember it is say grace before tea. So it's perfectly normal to see a little bit of swelling through here. If somebody has pes anserine bursitis, the bursa, which we don't see normally on ultrasound, swells up. So if I was to turn on that into the axial plane, so here's our sartorius attachment down, or our pes anserine attachment down here. Right, here's the tendons, they all merge into, looks like one on ultrasound. If we've got pes anserine bursitis, you'll get a C shape. So this hypoechoic C-shaped fluid will track around it. Now, depending upon how bad it is, that C can become an oval going all the way around it. Bottom line is, we don't normally see a hypoechoic halo around these tendons. If you do, that's abnormal. So that's the medial aspect of the knee. Now, if we just roll out and have a look at the lateral aspect, that's enough. Just bring it back a little. That's beautiful, thank you. So looking at the lateral aspect, to remember, the lateral collateral ligament doesn't have that intimate relationship with the lateral meniscus like on the medial side. I should have mentioned, if you tear the medial meniscus, you will tear the medial collateral ligament. Now, the medial collateral ligament has got deep and superficial fibres. You may just tear the deep fibres, so those superficial fibres may remain intact, preventing joint fluid from escaping into the subcutaneous tissues. But if you tear both of those components, the deep and superficial fibres of the medial collateral ligament, joint fluid will track out into the superficial tissues. So look for that. Now, I don't know if you can appreciate it or not, but see this little area bumping up and down here? That's the lateral genicular artery. Perfectly normal structure. That should be there. You don't always see that, but we can in this case beautifully. So here's our lateral meniscus once again. This inverted echogenic triangle, perfectly normal. Over the top of our lateral meniscus, we have our lateral collateral ligament. Now be aware, when the lateral collateral ligament tears, it can swell up to like 5 times its normal size. This is normal size through here. It can get huge. So sometimes I say, well, you're not seeing the wood for the trees. In other words, the abnormality is so pronounced that you don't appreciate it. So be aware that it can get very big. So there's our lateral collateral curling around from our fibula up onto the distal aspect of our lateral femur. Now, I'm moving a little bit more anterior. A little bit more anterior. And this structure here, so this is inserting onto the tibial tuberosity, so the proximal anterior aspect of the tibia. This is the distal aspect of our iliotibial band. It just looks like a ligament because that's what it is, so that's fine, right? Now, if somebody has irritation of this, it's called runner's knee, right? Now, when somebody has that, they can have problems at the insertion point, but make sure that you go and examine a little bit more proximally, up around this area here where the popliteus tendon sits. Reason being is that, like in the ankle and the knee where you've got Kager's and Hoffer's fat pad, there's a fat pad that sits deep to the iliotibial band. That can become irritated, and that can be what gives the patient all the pain. So make sure you scan a little bit more proximal for the iliotibial band, sort of up around here. Look at the cortical surface. Is it nice and smooth, as in this case? A little bit of roughening is fine. Remember, this is very magnified, so we'd be looking for more marked roughening than that. The tissue planes are maintained. You can see discrete tissue planes adjacent to the bone and then the fat and then the iliotibial band. When this becomes all irritated, it becomes echogenic and you just lose those different tissue plane definitions. Now, if we're staying on the lateral aspect of the knee, an important structure is the common peroneal nerve. So our sciatic nerve, when it gets down to the level of the knee, branches into the tibial nerve and the common peroneal nerve. The common peroneal nerve courses out from the posterior aspect of the knee and around the neck of the fibula. So here's our head of fibula. You can feel that. We come down a little. So there's our fibula here. Right, tibia's over here. Are coursing around the neck of the fibula, we have our common peroneal nerve. Now, why is that important to know? It's important to know because fractures of the head of fibula can lacerate that nerve. So it's important to go looking for that. Ankle inversion injuries, whereby you damage the structures of the ankle, the force can be transmitted up and you can get a fracture of the head of fibula as well. It's called a Massenet fracture. So just be aware of that. So here is the common peroneal nerve. Right? Has that bunch of grapes appearance again. It's not as well defined, it's not as sharp the edges, that's normal. I look for the echogenic area around it, or hyperechoic area, or hyperechoic area around the nerve, and that's normal, right? So then we can, here's the nerve here, turn through 90 degrees, and we can try and extend that nerve out into the longitudinal plane, going through here. That's perfectly normal. That's what you would expect to see. Now, between our proximal tibia and our fibula, we have a joint, funnily enough, called the proximal tibiofibular joint. That joint can be damaged and we can get a ganglion. So a ganglion is like an outpouching of that joint. That ganglion can communicate with the common peroneal nerve because they're so intimately related, right? They're so close together. And then over time, that joint fluid can actually track up the common peroneal nerve into the posterior tibial nerve and then up the sciatic nerve into the posterior thigh. It can be quite dramatic. I've never seen it in real life, but it's something that I always have a look for. Now we're going to have a look at the posterior aspect of the knee. So if we can just extend that knee just a little. So what I look for in the posterior aspect of the knee is I look for a joint effusion, obviously, if there's increased fluid. Even though you're not being asked to do a DVT study, I still have a quick look, right? So we can see the vessels back here. I just quickly compress. I quickly compress to make sure that that popliteal vein squashes. Right. Here's our tibial nerve, posterior tibial nerve sitting up here, that extension of the sciatic nerve. The common peroneal nerve branch has already come off. And down here we've got our popliteal artery. So I give it a quick squeeze, good, no DVT there. There's the artery, quick survey through the artery, no evidence of an aneurysm. That's important to pick up a popliteal artery aneurysm because popliteal artery aneurysms often go undiagnosed. If they pop, about 30% of people lose their leg. Right, so while you're there, it doesn't take 2 seconds, have a quick look and make sure there's no aneurysmal dilatation of that popliteal artery. Now, if we go behind the calf, and I just slide the probe inferiorly a little, right, we'll just adjust these imaging parameters so you can see the subcutaneous tissue a bit better. So this little, triangular pyramid-shaped structure here is where the short saphenous or lesser saphenous vein sits between the medial and the lateral gastrocnemius muscles. So as we go up the leg, this is all medial gastrocnemius, here's the veins in here, right, between the medial gastrocnemius and the semimembranosus tendon, which is this echogenic area through here, is where we get Baker's cyst forming. So a Baker's cyst is a congenital or an acquired defect in the capsule of the knee joint, whereby a tongue of the knee joint capsule extends out because it's been torn and knee joint fluid tracks through there. So here's our medial gastrocnemius muscle, and there's our semimembranosus tendon. So we can go through 90 degrees on that, and we can see that fimbrial nature of the tendon. So be careful of anisotropy in here, because if you angle your probe, you can make that semimembranosus tendon appear hypoechoic, giving the impression that the patient has a Baker's cyst. So make sure you're at right angles to the structures. You don't want to give them a Baker's cyst if they don't have one. The last thing I look at in this posterior aspect of the knee is the posterior horn of the medial meniscus. So I've slid my probe over to the medial side of the knee again, and I'm looking for this echogenic inverted triangle, and here it is here. We can see the posterior aspect of the distal femur, there's the articular cartilage, there's the tibia, and we've got this lovely inverted triangle of the posterior horn of the medial meniscus. We can have meniscal cysts here, so if the meniscus is torn, we can have joint fluid tracking out and forming a cystic structure there. And that's a knee ultrasound. Thank you.